Well, hello everybody. I'm Abby from Drop Bio Health, and it's my pleasure to welcome you to today's event on male fertility and sperm count with Dr. Hossam Elzeiny from Virtus Australia. Before we start, I wanted to tell you a little bit about how we at Drop Bio Health can help you to know your body and own your health. Connect with our community to understand how committed lifestyle adjustments can improve your health in the long term. Learn the latest evidence-based health insights brought to you by our network of wellbeing experts, and take the wellbeing test to see how your habits impact your health. With only a few drops of blood, the wellbeing test allows you to gain insights and track changes across sleep, stress, energy levels, nutrition and diet, exercise, inflammation, and alcohol consumption. Don't forget to follow us on our social media channels to keep up to date with our events and health resources, and join the waitlist to take the wellbeing test, which launches today. We're excited to share that all waitlist members will also receive a complimentary physical and mental health assessment from the Asana team, valued at $199 with the wellbeing test. To join, visit our website at dropbio.com or via the waitlist link in the chat box. So today we're really excited to welcome Dr. Hossam Elzeiny from Virtus Health. Hossam is one of the few reproductive endocrinologists in Australia who can help men with zero sperm count using the most sophisticated microscopic sperm extraction procedure. Today, Dr. Elzeiny will talk about all the factors that play a role in male fertility, from genetics to sperm testing. Welcome, Hossam. What's led you to focus on male fertility in your work as a reproductive endocrinologist and infertility specialist?
That's a very good question because I have that unique interest in male infertility, but it's basically because you will hear from the presentation that male infertility nearly contribute to half of the causes of infertility, and most of them, fortunately, can be treated with the technologies and the techniques that we have, but others will need an extra expertise to deal with. And I'm lucky that during my earlier years of training, I managed to get that kind of training and experience.
Yeah, I mean, it makes sense. Half of the equation in terms of reproduction would be male. So I guess that sort of stacks up. Do you think there's some changing sort of attitude and perception, as you know, in regards to the male role in fertility when people are thinking about fertility and issues they may be experiencing?
Yeah, for sure. Definitely, there is a big difference between how the female approach that problem and how male approach that problem. Male usually a little bit discreet when it comes to this, they probably wouldn't express how they feel compared to the female partner. But we are trying to encourage them to be involved, and as I said, like it takes two to tango, and both of them have to contribute from the psychological and the physical point of view.
Yeah, excellent. And it's wonderful to see that we have a few men in our audience today as well. Well, that probably brings me to the point in terms of just a little bit of housekeeping before we jump into this topic. If you have any questions that you would like answered by Dr. Elzeiny, you can submit them in the chat box, and I will read them out to him at the end of his presentation. So it's on the right-hand side of your screen, or on a computer, or look for the speech bubble icon at the bottom of your mobile phone or tablet. If you have any questions that you would like to put through anonymously, you have the option to do that as well. And for anyone asking if this will be recorded, it will, so you can share this with partners, loved ones, or anyone else that you think may benefit from hearing about this topic. But for now, let's jump into it, and I will hand over to you. Thank you, Dr. Hossam.
Thank you very much, Abby. And also, I'd like to thank Catherine as well, both of you, to organize that webinar through the Drop Bio.
All right, I'll leave you to it.
Thank you. Let's start. So, as you can see, we are going to talk about male infertility and sperm count today. As we said before, if we look at the causes of infertility, we'll find that about a third of the causes is related to female problems, and another third related to male problems. and that means about 30% is, say, male factor infertility. And then you have another 20% where they are combined between male and female factor together. And that makes the male factor contribution is about half of the causes of infertility. And it is the second largest cause of infertility in couples after, obviously, female infertility. And a 1 in 20 men will have a low sperm count, and about 1 in 100 will have the severest form of male infertility, which is the azoospermia, where we will not find a sperm in the ejaculate when we do a semen analysis. No one can know that unless you do a semen analysis. Um, Next slide is an important slide. It talks about the causes of infertility. I'm going to spend a little bit of time here in this slide because this slide gives you a lot about the causes of infertility, also the therapeutic approach, and also the investigations, what we do. So we start with the chromosomal makeup. So every male who have a normal sperm formation, they are going to have a normal male makeup, and that's a 46 chromosomes, including the 6 chromosomes which we call X and Y. So any man have 46 XY. Most of us knows that. And what happened here is that there will be problems in the sperm formation if, for example, the Y chromosome is lacking the important genes that is forming the sperm. And this is an important test that we do called YQ microdeletion when we are looking for the missing genes that are responsible for the sperm formation. What are other chromosomal abnormalities? We may have another extra X chromosome there, and that make the full makeup is 47, and that's a very famous condition called Klinefelter syndrome. So these men usually have no sperm in their ejaculate. Okay. Also, if that Y chromosome is replaced by the X chromosome, so 46XX, that's the female genotype or the female makeup of chromosomes. But you can also have a genotype 46XX, but they will look from the outside as a male. So they will look completely as a male. But what happened is that the genes that are responsible for the sperm formation on the Y chromosome have been translocated to another chromosome. And these men obviously will not have any sperm in their ejaculate. So the chromosomes is the most important thing. So the presence of the Y chromosome is what determine that our gonads, when we are still at the beginning of the formation, will be differentiated into a male testis or a female ovary. So that all depend on the presence of a specific gene on the Y chromosome. Okay. So the chromosomal makeup is sometimes a test that we do to check if someone present with azoospermia or no sperm in their ejaculate or very, very low sperm count. And then what happened after that? We have the testis has been formed. Then the hormones or the axis between the hormones released from the brain to the testis has to work properly. So the brain has an area called pituitary gland, is producing two important hormones called FSH or follicle stimulating hormone, and another one called LH. The LH will go to the cells inside the testis that form the testosterone. Okay, and the FSH will directly help with the sperm formation in the tubes that are inside the testis, which we call seminiferous tubules, and the sperm is formed on the wall of these tubules. So you have to have this axis working properly. You have to have the testosterone is produced in the right amount so the sperm formation will happen. The process of sperm formation takes about 74 days. Okay, so if there is any disturbance to this axis, then this can lead to male factor infertility. What are these problems? We divide them into 3 categories. The ones that are related to the pituitary gland, or we call it pre-testicular problems. This can be in the form of that the pituitary gland is not functioning well and not producing the FSH and the LH. And these could be due to two problems: either that it is a congenital problem, that the person is born like that and it is due to genetic problem. This is a famous condition called Kalman syndrome. And the other one is that after we do all the tests, we can't find a specific reason, but there is no production of FSH and LH from the pituitary gland. That's called idiopathic hypogonadotrophic hypogonadism, or that there is a tiny, tiny tumor in the pituitary gland called pituitary adenoma. This is another type of cells in the pituitary gland that produce the prolactin, which is the milk hormone. When it's very high, it can lead to male infertility and also erectile dysfunction as well. And then we have the other level in which we say post-testicular, which means after or the all the tubes that connect from the testis to the outside, there may be a blockage there, and this is probably due to an obstruction. Most common reason for obstruction is usually when someone had a vasectomy. You obviously know that for sterilization purposes. So the person have had children, and he decided to stop having children by having the vasectomy. But sometimes things changes. He's in a new relationship or something happened and the couple wants to have more children and he had the vasectomy. Here we have one of two options: either that we do a microsurgery and we reverse the vasectomy, or we can directly we can leave the vasectomy as they are and we just can get the sperm directly from the testis by a very small operation called fine needle testicular biopsy, and the female partner here has to do IVF. The other things are due to infection, or the other obstructions that can happen due to infection, like sexually transmitted diseases, or they may be congenital, like you are born with a missing part of the tube. And that's the common scenario is that the male partner will have a condition called cystic fibrosis. Not the condition itself, but if you are a carrier of cystic fibrosis and not having the cystic fibrosis, this can be associated with a missing part of the tube, which we call combined bilateral absence of the vase. So there is part of the epididymis here and the vase will be missing. And that means that the sperm formation is okay, but cannot find its way outside. This is also another test that we can do when we suspect that a person have obstructive azoospermia. The other things are associations, like you could have a varicocele. We don't treat every varicocele unless it is a high grade of varicocele. There are 4 grades of them. So it means the severe form, which is associated with pain and also associated with abnormalities in the semen analysis. Then here probably the surgery for the varicocele is required in that particular situation. Now, the third category is we call testicular. That means that there is a specific problem that happened directly to the testis. One of them is the chromosomal abnormalities that we spoke about. Lifestyle can affect the sperm formation in the testis directly. And there is a congenital problem called undescended testis. We know that the testis of any male should come down. So it starts when it's developing inside the uterus of the mother. It is in the abdomen, and then after that it goes down to the scrotum at the time of delivery. If this didn't happen, we have that condition which we call undescended testis, which means that the testis will stay in the abdomen. Problem here is that the abdomen is having a higher temperature, and higher temperature can affect the sperm formation. And if this testis hasn't been brought down to the testicle in the first 2 years of life, then we may expect to have problems in the sperm formation in the future. And if there is a direct problem to the testis, like someone had a cancer somewhere else, and then he started to have chemotherapy or radiotherapy, we know that all these medications can destroy the testis and result in no sperm production later on. And one of the advice that we give to these men who have been just diagnosed with cancer is to try to do sperm banking. Just give a sperm sample. Hopefully there will be sperm there, and this can be frozen for the future and you don't have to worry if there is any problems can happen to the testis due to the chemotherapy or radiotherapy. Immunological problems, we know that there are a lot of immunological problems that we call autoimmune disorders, in which the body can produce antibodies against its own tissues. And one of the things that can happen is to form antibodies against your own sperm. There is a test for that that can be done called sperm antibodies, and only significant if we have like 50%, more than 50% of sperm antibodies formed against the sperm. The sperm antibodies can make the sperm unable to move, unable to fertilize the egg. So that can lead to infertility if it is significant. Also, there is a famous condition called Sertoli cell only. We only diagnose it after we take a testicular biopsy and there is no sperm there. We find out that there is only that Sertoli cell, which is the supporting cells in between the cells that form the sperm. So in this case, you will not find any sperm forming cells there, but you will only see these Sertoli cells. This is the most severe form of azoospermia. And also if there is an exposure to a trauma while somebody is playing footy or something like that, or the testis can sometimes be twisted from this area, and the blood supply can be cut to the testis, and this is an emergency. If we don't do a surgery to untwist the testis can damage. Okay. Also infections, like especially moms after puberty, this can directly actually affect the sperm forming cells inside the testis. Or if someone had a neoplasia or cancer of the testicular cancer itself, it can also affect the sperm formation. So these are basically all the problems that can happen to any which can explain why there is a male factor infertility there. I think this slide is very, very important to know, and that will be the basis for what we are going to say after that. So after this, if we have a male who have a semen analysis and there is no sperm in his ejaculate, or there is a very, very low sperm count, specifically if it's less than 5 millions, then we start to take a detailed medical history from the patient. So we look at the even we take history since you have been born. As I said, we ask the patient if you had a history of undescended testes. Did you have to have an operation to bring the testes down? Or sometimes you can have a hernia in the inguinal area, and sometimes like the surgery to fix this hernia can actually sometimes take the spinal cord with it, and this can also lead to some sort of obstructive azoospermia as well. So the developmental history is so important. And then we ask if the patient have any medical problems, like diabetes, for example. This can affect the person in terms of so many complications that can happen out of diabetes if it's not well controlled, like say retrograde ejaculation, where instead of ejaculating to the outside, the sperm can go back into the bladder. This can lead to infertility. Okay. We also ask about surgery. Okay, some patients who may have the surgery that we have mentioned before, like herniorrhaphy or dealing with inguinal hernia, can also affect the sperm formation. Also, reproductive history, we have to ask the couples, like if there is any sexual problems, any erectile dysfunction, and also the most importantly is the timing of intercourse, because we need this to happen exactly around the time of ovulation. And if not, then it will be 5 days before ovulation and 1 day after ovulation. This is the fertile period of the lady. We also ask them about any past infections like sexually transmitted diseases or respiratory infections, because this can be a sign of cystic fibrosis as well. And we have mentioned why for the cystic fibrosis. If someone had any trauma, we ask them directly about that. Or any surgery to the genital tracts. There are a list of medications that can affect the sperm formations. We ask them if they are taking any medicine. And the most important thing is the steroid. Okay, the steroid, if you are using steroid for say bodybuildings or something like that, that can stop the sperm formation completely. But it is easy to reverse that process. Okay, and we ask them if there is any family history of any males who have a similar problem in the family. So the lifestyle is so important, okay? And you all know what are the lifestyles, usually smoking, alcohol, anyone using drugs like steroids, obesity, and even stress, and the if there is stress can lead to obviously sexual problems that may end up with infertility. Problems with the lifestyles is that although we always say, okay, that this factor affect the fertility and this affect the fertility and so on, there is no concrete or robust studies that have been done which tell us, okay, we have, say, smoking or alcohol affect your fertility. And then there is no studies that have said, okay, if you stop the smoking or the alcohol, then your natural fertility will go back. Obviously, the people who have already problem there, like low sperm count, but it's not, say, for example, dramatically low. All right. So these people will probably need to adjust their lifestyle because every little thing can add to their fertility here. Now, most of the lifestyle will affect the sperm in this way. You will find studies will tell you, okay, if you smoke or you drink alcohol or if you are obese, you can have problem with the sperm count. The sperm count can be low. The motility of the sperm, which means the percentage of the sperm that moves in the right direction, right speed, could be affected. Okay, or even the shape of the sperm can be affected. We only need 4% of the sperm to be just of having a normal shape to consider that semen analysis is normal. But you have to be aware that it doesn't mean that you have a normal semen analysis that you are fertile. And it doesn't mean that we have a low sperm count that your sperm is infertile. So as you can see, the semen analysis is a quantitative test, doesn't tell you about the quality of the sperm, because the quality of the sperm is usually determined by the quality of the egg. Okay, so that particular egg of your partner, all right, when it interacts with your sperm, that's the real test for the sperm. Okay, so the female partner could be of a young age, and in these situations, even if the partner have slightly lower sperm count, they will not realize that there is a fertility problem there. Okay, if the female partner is older in age, like above 40 or something like that, then we start to have issues here. The older egg may not be able to deal with problems that the sperm may bring. Okay, so we need to understand that very, very well. And that's why it's so difficult to pinpoint that there is a specific lifestyle can lead to infertility. Okay, for example, if we are smoking and we have done studies and say the normal sperm count is usually between, and we will come to this, between 15 and 200 millions, right? Say if this person have, and this is exactly what happens in the studies, he has a count of say 40 millions. And because he is a smoker, like after smoking, for example, okay, so that 30 millions may go down to say 14 millions. Doesn't, but it has decreased the count, right? But it may not have affected the fertility of that person. Okay, but there are certain things which is very obvious, like being obese, right? This is very, very important because when you are obese, okay, the sperm formation will be affected definitely for from different mechanisms. So the scrotum is an area always which is very, very hot, and sperm formation can be affected that way. Secondly, when we are obese, there is a special enzyme there that convert the testosterone that you have into estrogen, and that in itself can affect the sperm formation itself. Okay, so definitely the steroids, when you take steroids, it can actually bring the sperm down to zero. And that's why we bring all those 4 lifestyle factors out of the list, because these are the ones that are more likely to affect the sperm formation. The investigations, after I take a complete medical history, I will do a physical examination, and most likely I will concentrate on the testicular size and the presence of the tubes that connect the sperm from the testis to the outside. Obviously, the semen analysis is the cornerstone. We start with the semen analysis. If it's normal, we don't need to do anything else. Okay, but when there is abnormalities there, then we start to do these further investigations. We are not going to do these tests if the semen analysis is normal. The further investigations like blood tests and the hormones, we obviously check the FSH and the LH and the testosterone, as I mentioned before. The genetic testing, we will check the whole chromosomal makeup and the Y chromosome microdeletion. Okay. With the semen analysis, what's the normal semen analysis? That's according to the WHO criteria. We look at the volume of the semen, because this is very important, and it should be more than 1.5 ml. You can actually, by just provided that the whole volume came out on the jar that you are given to give the sample in, provided that you have given all the sample there. If it's less than 1.5 ml, and there is a problem with the sperm formation, like there is no sperm there, for example, then I would suspect that you may have blockage somewhere. So just from the volume of the semen analysis. Okay. Concentration, as we said, it should be more than 15 million per mil. Okay. And the total sperm number should be more than 39 millions, because you are more likely going to have like a 3 mil of volume, and you multiply that by the 15, you will get that number. Motility, which is the which is the percentage of the sperm that moves in the right direction, right speed, we should have at least 32% of the sperm moving. And then the shape of the sperm, as we mentioned before, we need at least 4% of the normal shape. See, any man will produce a lot of abnormal sperm, and that's why it is produced in millions. But we only need 4 millions of the sperm to be having a normal shape. And the sperm antibodies that I have mentioned before, if it's less than 50% of the sperm is attached to the antibodies, I will consider that normal. If it's more than 50%, then becomes significant, and this could be a reason for the infertility. So as we said before, the andrology tests will be the routine semen analysis that we mentioned, the sperm antibodies that we mentioned before as well. There is an additional test which has been introduced recently called sperm DNA fragmentation. So you are looking for healthy sperm who has intact DNA. And also we do that only when we are doing, say, artificial insemination or IVF. We try to wash the sperm and centrifuge it, and then we try to see what's the changes that can happen. Sometimes you can have a man who have a low sperm motility, for example, and after you do the wash, the motility can improve. It was, say, for example, 20% before, you need 40%, you can have here 60 or 70% after the wash. Okay, so all these lab techniques can improve the sperm quality. Now, when we get the results will come back and say, all right, we have a normal semen analysis, or we have azoospermia, which means that there is no sperm at all, can be seen under the microscope, or we have severe oligospermia, which means that the count of the sperm is low and it is lower than 5 millions. That's severe oligospermia. Or another significant abnormalities, like you may have abnormalities in the three factors there, like the count is very low and the motility is very low, and the shape we have less than 4% normal shape. Then here we have a significant abnormality, or these trio together. Okay, so all these things has to be matched to the WHO parameters. We mentioned those things before, like the blood investigations, like the hormones. These are all the hormones that we look for. The genetic testing, again, like cystic fibrosis and the karyotype, or the Y chromosome microdeletion. So we mentioned those in the first slide when we were talking about the causes of male infertility. Now, the ultrasound, we don't ask for the ultrasound routinely, okay? But we ask for the ultrasound, could be on the scrotum, scrotal ultrasound. And that's after the doctor does his examination. If you feel any mass or tumor or any unusual varicocele, then here you ask for the scrotal ultrasound. Okay. And then if there is obstruction there, then there is a different type of ultrasound called transrectal ultrasound. We look for areas that could be blocked and lead that to that there is no sperm that can come to the outside. Uh, One of the most famous ones is that you can have a cyst in the duct called ejaculatory duct. So there is a gland, okay, after the sperm leaves the testis, can also produce some secretions and also help with passing of the sperm to the outside. If there is a cyst there that block this area, it can be picked up by the transrectal ultrasound. And also it can be treated surgically. If you just take this cyst out, then the passage of the sperm will be okay and it will come out as per normal. And again, the scrotal ultrasound will detect if there is any testicular tumors that need to be further having a further investigations to find out what's the type of the tumor and so forth. The sperm cell is very unique. You see, it is very, very tiny, tiny cell. And if you look at the head of the sperm, uh, it doesn't look like the usual cell. The usual cell, like the egg cell, for example, the egg cell is the biggest cell in the body. It has a nucleus inside that has the genetic material. The genetic material is actually half of the number of the chromosomes. And then you have something else called cytoplasm. They have all the machineries that help with the metabolism and everything. But with the sperm cell, it's so tiny. So you see that sperm is so tiny, and it is occupied mainly by just the chromosome, and they are packed there and they are compacted, so the sperm can go inside, and then after that they expand, and then they combine with the other half, with the nucleus of the egg, during fertilization to form the right number of chromosomes. So that's the main reason, but there are other reasons that also very important that result in fertilization, and also because the sperm has the factor that initiate the process of fertilization, and then the egg respond to it in a cascade of events until fertilization happen, which means that that the nucleus of the sperm combine with the nucleus of the egg. That's the first event that happened for us as a human being, is fertilization. Okay, and then that one cell that has formed the full number of chromosomes divide into two, and the two divide into four, and so forth. And during division, they have to divide with the right number of chromosomes. If there is any abnormalities here, then we will have abnormal fertilization or abnormal embryo development. We only see these things when we are doing IVF, okay? But this also happens in nature, but we can't see those things. So the sperm cell is very unique in that respect. Again, one of the things that the test that we can do is to check if there is any much damage to the DNA of the sperm. This can happen for men who are having an older age, and basically any of the conditions that I have told you in the causes, now everyone is trying to link the cause or the DNA fragmentation to the cause. So you will find always DNA fragmentation there. For example, in the past, we were talking about varicocele and how varicocele can affect the fertility, okay, sperm count, motility, shape, whatever. But now they have said that okay, now there is an evidence that there is a DNA fragmentation that can happen, or DNA damage as well, to this situation. But we don't, this test at the moment has not been routinely, is not routinely ordered after the semen analysis, but only we order it for certain situations. In particular, if, say, for example, a couple has been doing IVF and they are not able to form good quality embryos, right? Here I may check for the DNA fragmentation. Okay. Another situation is if a woman have recurrent miscarriages, then I can check for DNA fragmentation. So not being asked to be done routinely. right? Um, so the treatment, what are the treatments which is available? Obviously, hormonal treatment. Hormonal gonadotrophins are the FSH and the LH that we were talking about. Okay, so this is very effective treatment for men. You remember the ones that we mentioned when they are not producing FSH and LH either uh, since they are born or something happened to them and they are not producing those hormones. After we do the investigations and we know that this is sure this is the case, then we can treat them with the FSH and LH. We give them injections, usually for a longer period of time, because the sperm formation, as we said before, it takes about 74 days. So you need a minimum of 3 months until you see an effect there. Okay. Now, androgens. Androgens here, we usually talk about, say, testosterone, but that's only for men after we say, for example, they may have a low testosterone level and they have an infertility problem. They may not have sperm at all. We may have done a surgery for them, microsurgery to get sperm. And then after that, they will need to have an androgen replacement therapy, testosterone replacement therapy. So they will probably have that testosterone for life. Okay. Antioxidants, which these antioxidants is important for patients who have a high DNA fragmentation. So if you have a high DNA fragmentation in the sperm, like high DNA damage, there is a few things that can be done. Simple things like frequent ejaculation, for example. So if you ask that person to have frequent ejaculation, like ejaculate every day, all right, and then you do a sperm test, you will find out that you will have less DNA fragmentation. Although you will have a lower volume, but you will have a better quality sperm. This is very, very important advice, frequent ejaculation. Now, what else that we can do for the DNA damage? There are certain lab techniques that we need to do, okay, that can also decrease the damage to the DNA. What other things that can be done? Sometimes when things are severe, then we may actually take the sperm directly from the testis. So that person can produce sperm in his ejaculate, but he has a high percentage of DNA damage there. Then we can take the sperm directly from the testis, because the sperm that we take directly from the testis will have less DNA damage. Why? Because there is a reservoir there, or a tube, between the testis and the vas to the outside, called epididymis. The sperm can go there and stay for about 20 days. And that's when the sperm damage can happen. It's obviously is not going to happen because this is a natural process. It's not going to happen to all the sperms there, but there are certain situations that can make this damage happen in this epididymis before the ejaculation. So if you take the sperm directly from the testis, then you will have a better sperm. I have cases like that, and I found out that instantly I have magical uh, 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 like solutions to these cases. They usually will be situations where they are doing IVF and their embryos are not developing well, and we are telling them, unfortunately, we can't have a good quality embryo to transfer for you. And then if we do the DNA test for the sperm, we find out that there is a high degree of DNA fragmentation. Then my next cycle, I will say, I'm going to take that sperm directly. It's a very simple procedure done under local anesthetics. Okay, I will take the sperm directly. These are the particular situations that we will have an instant and amazing results for them. Okay. Obviously, patients who have obstructive azoospermia, we can treat that either by taking the sperm also directly from the testis, okay, before the obstruction, or if they can be surgically corrected. These are the solutions for the obstructive azoospermia. Now, in case we have very, very low sperm count, or there is a sperm problems, right? What we do, we can actually pick up one sperm only and then inject it directly into the egg. That will require IVF here, because I have to get those eggs from the lady, okay, through the IVF. And then I will just select the best sperm that I can see through the sample, and then inject one sperm, one only sperm, directly into each egg. So what happened when we have, say, normal semen analysis? I don't do that. We will just mix about 100,000 sperm, with each egg, and then naturally one of those sperm will fertilize the egg. So we only do ICSI if we have a problem with the sperm, like lower sperm count, lower motility, lower shape. That's the time when we will do the ICSI, or intracytoplasmic sperm injection. This technique has been introduced in 1992, and it has revolutionized the treatment of male infertility. So we really don't care too much if the sperm count is a little bit low, but we need to still investigate the man and make sure, because there could be a genetic problem that can be passed to the child. So I need to make sure that this is not going to happen, or what else I could do to prevent this from passing to the child. The man may have testicular cancer, for example. I need to pick up those things so we don't have a problem in the future. So you still have to investigate men who have a problem or a male factor, okay, to rule out the other things. But the good news is that a low sperm count is not a big deal now in the presence of the XC. So that's a very reassuring and very important thing. Now, there are so many tests, and we have selected some tests here and not all of them, that can also help with selecting. Okay, everything in what we are doing is about selecting. We try to select the best egg, we try to select the best sperm, we try to select the best embryo to transfer it back into the uterus. So it's all about selection. So one of the things that can be done here is that we can actually look at the sperm under much higher magnification. Normally, we look at the sperm under 400 times magnification. So we can go up to 6,000 magnification. So we look in particular to the details inside the head of the sperm. Okay, there is some controversial results. Some studies say that it is effective in treating certain conditions. Some say it's not. But this is another tool in our hand that we can use when things are not going as it should be, like in cases with recurrent miscarriages or recurrent IVF failure. Microsurgery, this is one of the things that I am proud to be doing. So things that we do something called microscopic testicular sperm extraction, or micro TC. Um, the most important thing before we do such a surgery is actually to make the right diagnosis. So for men who has azoospermia, we have to differentiate between if they have azoospermia or no spermia in their ejaculate due to blockage or due to something else other than blockage. The blockage is easy. Okay, so if you have azoospermia, you will be lucky to have obstructive azoospermia, because the factory or the testes that produce the sperm have no problems. All right, so we can just do a fine needle biopsy. This is a fine needle biopsy. So this is the simplest way of getting the sperm and the cheapest way of getting the sperm. I don't need to do the micro TC here for someone who have blockage. So this is so important. The most important thing here is the diagnosis. Is it obstructive or non-obstructive? So it's easy here. We can get the sperm directly from the testis via fine needle aspiration. Under local anesthetics, we just put a needle in and out and get the sperm. Now, if someone had non-obstructive azoospermia, this is the challenge, okay? Because in obstructive azoospermia, all the cases will have sperm, right? By doing this simple procedure. But in non-obstructive azoospermia, only half of them will have little tiny areas that form the sperm there. And just doing a fine needle biopsy here is not going to be effective, because more likely you are going to go to an area which doesn't have sperm there, because there is only tiny area that have the sperm. So you need here to open and do the microsurgery. Under high magnification, you look for that area that may have the sperm there. That's more invasive, not, it will take more time. It takes 2 hours to do that operation and needs higher skills, high microscopic surgery, and obviously is going to be more expensive than just doing the fine needle biopsy. All right, so it is very important not to mix the two, because I don't want at the end of the day to do a micro TC unnecessarily for a patient who have obstructive azoospermia. Patients also have to be aware of this, okay? So they need to be aware of what is my diagnosis so he can get the right operation to retrieve sperm. Obviously, if someone had a vasectomy before, then we can do the vasectomy reversal. But again, we will have the option also of doing IVF. What's the common scenario where I would go for IVF rather than vasectomy reversal? If the person say, I only need one extra child and I want to keep my vasectomy there, all right? Or if, for example, the female partner is older than 40 years old, okay? So maybe the reversal will not work, and after that, we may not have a good sperm count there after the vasectomy reversal. So that all takes time, and the female partner is getting older, and the chances are getting much less and less. The other thing is that if the time from the vasectomy till the proposed reversal is longer than 8 years. Anyone who is above 8 years since the vasectomy, then it's better for them to just have the fine needle biopsy, because longer than that, there will be other areas that will be blocked there, and you are not going there for one area which is blocked at the site of the vasectomy. So it's more likely that's not going to work this way. So when you have a vasectomy before, you always have these two options, and then we go through all these factors to determine what is the best way for you. Obviously, for patients who are having, say, very, very poor sperm quality, and it's extremely obvious, okay, that it is a male factor, and we are not able to get an embryo for transfer, then donor sperm here will be an option, okay? What are the other scenarios? If, for example, the person has azoospermia, and we have done the micro TC, and as we said, half of them will have sperm, half will not have sperm, and you couldn't find sperm, then you can resort to donor sperm. And there are other situations. Okay, if there is a, like a single lady or same-sex couples and so forth, then donor sperm here will apply. And we have the largest donor sperm program in Australia. And usually the donor sperm will be either known or unknown. Okay, you can actually choose what you want. And there is compulsory counseling sessions that will be given to the patients and the donors. And also there is 5 family limits for them. So the sperm donor can only donate to create 5 families. Obviously, we have alluded to the issue of low testosterone level, and you have a male fertility problems. So these men, after, okay, not before, after we help them to have their own children, then here we can give them the testosterone replacement therapy. We don't give testosterone to anyone who is planning to have a child, because by testosterone for a man is like the contraceptive for a woman. Okay, the woman take the oral contraceptive pill in the form of estrogen and progesterone. The testosterone is like a male contraception. When you take the testosterone and the levels in the blood goes up, then that will suppress your FSH and LH. The FSH uh, uh, will not control the process of the sperm formation, and you will end up with having azoospermia. And this is very obvious for men who are abusing testosterone for bodybuildings. I see a lot of patients like that in my practice, come to my practice. So as we said here, we don't give them testosterone until their fertility resolved. Okay, and obviously healthy lifestyle is very important. So although we don't have a concrete evidence that if you stop this or if you improve this particular lifestyle, then you are going to be fertile and you will have a child. We don't have studies that prove this, but it is important to encourage for a healthy lifestyle, because those factors can actually affect other health issues as well. And the difficulties in doing these studies, because most of the time you will find a man who is a smoker and drinking alcohol as well. So there are multiple factors which involved here, and it's very difficult to differentiate the two. Most of the studies done on animals rather than in the humans, okay? And sometimes it's very difficult to translate from the human to the animal. And most of the lifestyle factors are not causing infertility. They are associated with. Okay, this is a very important thing to know. Okay, so there is just a link, but not necessarily they are the cause of the infertility. Okay, unless there is something obvious, like someone is taking steroids and become azoospermic. Okay, so also the association with the testicular tumor should be investigated. Now, this is probably going to be one of the last slides here. What are the treatments available here? I put them on this slide. So first, we may have a partner who have, say, erectile dysfunction. Okay, then we need a due to a psychological problem. Then we just need to see a psychosexual counseling, okay, or a psychologist can see the couple, and the problem may be resolved by a couple of counseling sessions here, right? Medical treatment like the hormones that we talked about, okay, like FSH and LH. There are some other medical treatment that can be given, like Clomid or Letrozole. We have like about 4 or 5 medications that we can use uh, uh, to reverse and help improve the sperm formation. Surgical, we mentioned here that if someone has blockage, you may unblock the areas, okay? And the sperm extraction, which is surgically, either we do the fine needle biopsy or do the micro TC. And then if there is a mild male factor, like there is a little bit of a lower sperm count or lower motility, but not severe, then we can do intrauterine insemination. So what happened here is that the lady will have a small amount of hormones to ensure that she's going to ovulate. And on the day of ovulation, we ask the male partner to produce a sperm sample, and then we centrifuge it in the lab, as I mentioned before. That can improve his sperm motility, for example. And then we put it closer to the egg inside the uterus. That's called intrauterine insemination. So it can help with cases like this. And then if the sperm count is so severe, like lower than 5 millions, then here we have to do the ICSI, okay, or intracytoplasmic sperm injection, where we only select one sperm and inject it directly into the egg. Now, there are situations in which we will do that ICSI, and we know that there is a problem with the sperm. And then despite of this, the eggs has not been fertilized. ICSI actually is or that process is very, very effective in overcoming fertilization problems or absence of fertilization. But there are a small percentage of these couples will not have fertilization despite of doing ICSI, and the situation becomes here very complex and complicated. But we still have an option for them, something called assisted oocyte activation. So we during the ICSI, or when we inject the sperm into the egg, we expose the egg, which has been just injected with the sperm, to a solution that has something called calcium ionophore. The calcium is so important in initiating or it is actually in the middle of the process of, you remember I told you the sperm has a sperm factor there that initiate the process, and there is a cascade of events that happens after that, ending up with the fertilization. So halfway, the calcium should be released from from certain areas in the eggs, okay, to help complete the process of fertilization. And if that factor on the sperm is not there, then that process will not happen. So here we can just give that calcium and it can complete the process of fertilization that way. And most of the time, if this is a male factor problem where the sperm factor is absent or not working well, then this assisted oocyte activation will work very well. And I have a few cases, all right, which have failed fertilization after ICSI completely, and we managed to achieve pregnancies and having children out of them. And then at the end, sperm storage, that's only for men who are about to have chemotherapy or radiotherapy for treating cancer. Or if, for example, a man is going to have a vasectomy, for example, and we can ask him to do some sperm storage before that. Or if a man had a very, very low sperm count, like less than 2 millions or something like that, because he may be in the process of losing the sperm completely with time. So we ask them to store some sperm at that time, and we don't have to do a procedure to get sperm for him in the future if he developed azoospermia. And again, this is an evolving technology, and every day we have a new technology there that can help with selecting the sperm, mainly to help with selecting the sperm and improve the quality of the sperm. And in summary here, this is my last slide, I would say that the fertility and infertility in men is associated with a variety of genetic changes with uncertain implications for the future. Because the male infertility itself can be due to a genetic problem that we may not know about, and it may be passed to the child. It could or may not have implications, medical implications in the future. Simple clinical and lab assessment of the infertile male can provide useful diagnostic and prognostic information, like simple semen analysis. When we look at the volume of the semen and it's very, very low and there is azoospermia, we can actually, by doing that simple lab assessment, reach to a diagnosis. And a variety of new technological approaches and a wider number of men to be helped. So again, like it is an evolving technology, and there is major breakthrough that has happened with treating male infertility. So I think that's my last slide here, and I'm very happy for any questions now.
Thank you so much, Dr. Elzeiny. That was such a comprehensive look at male fertility. Gosh, there's a lot to it. And hopefully, well, surely there's a lot for people in the audience to digest and think about with that as well. And hopefully get a bit of hope and confidence around the many options that are available to them. So we do have time for a couple of quick questions. We're probably not going to get to all the questions that we had through from our community this week, but we will make some arrangements to have those answered and sent out to you guys as well. But please feel free to jump in and pop some questions in now. I'm going to launch straight into it, if that's okay with you, Hossam.
Yes, absolutely. Please go
Okay,
ahead.
let's start off. So Diana was wondering if the vegan diet can affect male fertility. What are your thoughts on that?
Yeah, I think the short answer for this is that there are studies that have been, many studies that have been done to look for the diets, especially in the female and male factor. And they found that if you are like the Mediterranean diet is the one that is associated with the best fertility compared to the North American diets, for example. And the Mediterranean Mediterranean diet will involve having lots of nuts, which contain a lot of antioxidants, fish and meat, and lots of vegetables there, and lots of olive oils. All these things can, like has been proven to be associated with a better fertility. I hope this have answered that question, unless you need specifics there.
Thank you. Well, we've got quite a bit of information and research on the Mediterranean diet as well. So we'll make sure that that's available in the community on
Yeah.
Facebook if anyone's wanting to dive a little bit more into that. Another question for you from Natalia, who asked, should men with recurrent miscarriages have sperm DNA fragmentation tests done routinely? And can it only be ordered by fertility specialists?
Yeah, I think I have alluded to this in my slides, and I said we don't ask for it routinely, okay? But recurrent miscarriages or recurrent implantation failure, I think it is one of the indications for doing the DNA fragmentation test. So not every lab is doing it, and most of the time, uh, not most of the time, I would say that only a fertility specialist will ask for it, because again, like it is a special test, which also has its drawbacks as well. So we haven't so this test, for example, there is so many tests that can look for the DNA fragmentation test, and none of them is perfect. Okay, so we have to be to be aware of this. So the test itself hasn't been perfected, but it is another tool or another test in which we can do for this group of patients: recurrent miscarriages or recurrent implantation failure. It will be important if, for example, the tests show that we have like a high percentage of DNA fragmentation. So we are looking at something like more than 30% DNA fragmentation. DNA fragmentation, by the way, is not bad, but it has to be like in a, and if you don't have a DNA fragmentation, you can have problems, but it shouldn't be exceeding like 8 or 10%. If it's more than 30%, then we may have problems here. And the good thing is that we have a treatment for this. As I said, if you are doing your IVF and you have repeated implantation failure, then the next step, if you have a high DNA fragmentation, then you will take the sperm directly from the testis.
Okay, wonderful. What is the first step for men who are wanting to really kind of get an understanding of their fertility picture? What would be the best first step to take?
Yeah, I think the first step, if he wants to check his fertility, is to do a semen analysis. Okay, basically the semen analysis is the cornerstone of assessment. But again, the this is just like a quantitative thing. We want the count to be above 15 millions. We want the motility to be this percentage and so forth, right? But the best test for the sperm is your partner egg. This is something that you really need to know. I'll give you an example. Say, for example, you have a couple who are relatively young. Say the lady is, say, 32 years old, and the man hasn't done any sperm test, okay? But actually his sperm count, say, 13 millions. That's lower than the 15, okay? So if you do a semen analysis and you look at the 13 million, you will say, okay, we have a low sperm count there. So his wife is 32 years old, and then they can have 3 children in a row until she's 35 or 36. And then she is now 41 years old, and then she feels like she want to have another child. When they try, provided that the sperm test hasn't changed at all, you will find that she's struggling. So her egg now is different than when she was 32 years old. Okay? Yeah. So the best test for the sperm is the egg of the female partner.
Okay, excellent. Thank you so much. Look, that's probably all we really have time for today in terms of questions. So we'll wrap it up there. But I wanted to thank you so much, Hossam, for sharing your time and knowledge with us today. Dr. Elzeiny is actually one of the Virtus Health experts in male infertility with the highest success rate in sperm retrieval. So we're really fortunate to have him speak with us today. If you'd like to learn more about Virtus Health and IVF Melbourne, get in touch with the team through their website and their social channels, which are linked below. I'd like to thank everybody for your time and your questions today. And as I mentioned, if we didn't get to your question, rest assured we'll endeavour to answer them all over the coming weeks on our knowledge hub at dropbio.com. There's a short survey at the link below also. If you have a few minutes to give us your feedback, it's truly helpful. We've put the link in the group chat box to join the waitlist for Wellbeing launching today. So you can take that test and see how your habits impact your health and claim that Asana Health Check offer also. And then finally, keep an eye out for the email with the event replay that'll be coming in the next couple of days, which will also include more information on wellbeing. But once again, thank you everyone, and thank you so much for your time and your wisdom, Dr. Hossam Elzeiny.
Thank you, Abby. Thank you. Thanks for all of the audience.
Thanks, guys. Have a wonderful afternoon.